I'm Dr. Srinivas. I'll be talking to you on the central and inner ear histaminergic system in the context of vertigo. It looks very complicated, but it's not going to be like that. Conflict of interest to declare, I'm director and co-founder of Cyclops Medtech Private Limited, a company focused on making innovative diagnostic products for vertigo and episodic neurological events. They have a stall there with our first VNG product. The structure of this talk is going to be, we are first going to deal with the vestibulo-ocular reflex in health and disease, the role of cerebellum in motor learning, and then after that, the way histamine modulates that in the motor learning. Okay. The vestibulo-ocular reflex. All of us know the vestibulo-ocular reflex serves the purpose of providing stable vision. Okay. So when I am looking at something very, very stable, okay, and with my head shaking, which generally naturally keeps happening when we are moving, when we are walking, we look at one fixed point. That particular point should have make a fixed image on the retina. If it moves, there is going to be a problem with the acuity of vision, which means the eye should move in the direction opposite to my head. If I am looking here and I look this way, the eye should move in the opposite direction, and if I look this way, the eye should move in the opposite direction, so that this is maintained. The stability of vision is maintained. This happens through a beautiful vestibulo-ocular reflex. The inner ear detects my head movement, and through a 3-neuron arc, the eye moves to the opposite side, which happens with a latency of 5 to 8 milliseconds. You can try that immediately, simple. Put your hand, thumb forward, try to shake it. You make more than 2 cycles per second, the vision deteriorates. But then you hold your thumb, you shake your head, even 10 cycles per second, still you get very, very clear vision. You can test it right now and it works. Okay, that happens because of the robust vestibulo-ocular reflex that God has provided us with. So this is the key. But this vestibulo-ocular reflex, there has to be a context specificity of this vestibulo-ocular reflex. Now, if I am just holding something like this, and then along with my head, if the object moves, then the vestibulo-ocular reflex should not work. If it works, it is going to compromise my vision. So at that time, the vestibulo-ocular reflex should be switched off. Then when I am looking something close and shaking my head right and left, or when I am looking at a distance and shaking my head right and left, the eyes, when I am looking close, should move more. When I am looking at far away object, the eyes should move less. So all the context-specific changes, the vestibulo-ocular reflex should take care of. And all this is possible. There are the vestibulo-ocular neuron, the vestibular nucleus has different areas for different functions. Like when I'm looking at a specific fixed target, there is something called position vestibular cross neurons, which are very, very active. When I'm tracking something that is moving slowly, those neurons are something called eye head cells become very, very active. So that is how the brain takes care of shifting between contexts. And then the other thing that happens with the vestibulo-ocular reflex is that it is very, very adaptable. The moment you wear a new pair of glasses, whether they are magnifying or you are learning the use of a loupe or a microscope, whatever it is, for the same amount of head movement, the same amount of eye movement will not work. So the brain has to relearn how to adjust to the new. So the gain of this reflex, the previously it used to move by 30 degrees for a 30-degree angle of head movement, now it has to be either less or more. All these learnings our brain is capable of. And the moment you take off the surgical loop or take off those spectacles, it is go back to old. So again the context specificity comes once the learning happens. This is the beauty of our peripheral and central vestibular system put together. The moment you remove, what happens in what happens if you are in unilateral labyrinth failure? The way labyrinth works is a push-pull mechanism. To explain that, what happens when there is a lateral rectus palsy? When there is a lateral rectus palsy, it is quite understandable that I cannot move laterally. But why should it come medially? Why should it come and rest medially? It comes and rests medially because of the unopposed action of medial rectus, which means there is a resting tone of the medial rectus. Similarly, when it comes to vestibulo-ocular reflexes and the way they run, there is a resting tone on this side, there is a resting tone on this side. Both of them are equal or stable. They are unequal, there is a problem. One inner ear is cut, unilateral labyrinthine failure, there is there is an unequality. Unequality means you start getting a perception of doing it one side and the eye starts bobbing to the other side. The role of cerebellum in motor learning. What exactly is cerebellum? We've been from first year MBBS, we've been reading about cerebellum, what happens, what is this, what does it do? The cerebellum gets inputs from throughout the brain to tell what is the goal. Like if I have to take a ball and throw it at something, that is the goal. I want to hit a particular thing. To achieve that particular, so that signal goes to the cerebellum. When you achieve that particular goal, there is a particular motor output that comes from areas of the brain. That also goes to the cerebellum. Then what exactly is achieved, whether it has hit the target, not hit the target, or whatever it has happened, that also reaches the cerebellum. All these things are correlated. If it is happening correctly, fine, that will be strengthened, that pathway is strengthened. If it is not happening correctly, that pathway is again retuning and correction and all these happens. And that is how this happens. Especially when it comes to the eye movement, and fast movements of the eye. I'm looking here, I need to look there. I should not overshoot, I should not come back. There is no stretch reflex in the extraocular muscles. It is something like shoot and forget, like a missile. It has to be right the first time. So, because it happens very fast. I can't, mid-flight, I can't change the course. So, the start of the course should be very, very correct. So, and whether it can achieve or not. If it achieves, if it overshoots the targets, undershoots the targets, the cerebellum again understands I need to change the gain, these things. This is how it does. Now, we need to come to a concept of neurotransmitter versus a neuromodulator. Okay, so for that, we need to see this particular slide. What happens here, you see, in the center synapse, from there the axon to the next dendrite, there is a connection, there is a synapse. Okay, that synaptic transmitter is a neurotransmitter. But extrasynaptic will be receptors on the cell body. Those extrasynaptic receptors can also be activated. So, next time when the signal comes from the other neuron to the lower neuron, whether that signal should get transmitted, should be enhanced and transmitted, inhibited and transmitted, or totally blocked, can all be controlled by extrasynaptic receptors and ligands. Okay, so they are neuromodulators. So we have neurotransmitters which are within the synapse, there are extrasynaptic receptors which are neuromodulators. Okay. And how does this new learning happen? When something wrong happens, that particular pathway, neuronal pathway is wrong. So that should be suppressed. When it happens correctly, then that should be activated. So how does that happen? That happens by these synapses being either strengthened or weakened. So that strengthening and weakening that happens over a long term, they are called long-term depression and long-term potentiation. So again come to the same neurotransmitter. Now I need to introduce the concept of inverse agonists. When we talk about any particular molecule, and especially in the context of histamine that I am talking about, we have the classical beta-histine, which is said as H1 agonist and H3 antagonist. Is it an agonist or is it an antagonist? We get confused, right? Is it actually an agonist or an antagonist? Now, if this particular molecule is histamine is secreted by this particular neuron on that terminal bulb, and there is a receptor on the cell body, and that cell body can take the same, what is secreted there, if it can go back there and give a negative feedback. Negative feedback is, okay, there is enough, you stop. If the negative feedback receptor is blocked, if it is blocked, that is an antagonist. But it will actually become more and more. So, though it is one particular receptor antagonist, actually the action is agonist. So that is why these are called, though we call a H1, H3 antagonist, it is actually something that will make the histamine to act more, or more histamine to become available within the brain. And when it comes to the brain histaminergic system, when it comes to the periphery, the histamine comes from mast cells mainly. In the brain, it is secreted by neurons. They are originating from the tuberomammillary nucleus. So from there, these neurons go, the dendrite connections go throughout the brain, including spinal cord, cerebellum, everywhere, to show their neuromodulatory effect. And that is why the actions of histamine and antihistamines are so profound. When it comes to sleep-wake cycle, food regulation, everything, it is so profound. And where exactly are these histamine neurons located? When it comes to the vestibular nucleus neuron, you see it has ligands. I mean, it has receptors for so many different ligands, and you can see there, it has also for histamine, for 5-hydroxytryptamine, GABA, everything, dopamine, everything it has. When it comes to even the periphery, the vestibular afferents in the inner ear, there also you see H3 receptors. So what exactly and how exactly do these H1 agonists or H3 antagonists for that matter bring about a change, bring about an action? They help, they are being neuromodulators long term, they help in bringing about that long term potentiation of what synapses needs to be strengthened. That is how the new learning happens. This action is brought about through cytoplasmic protein kinase T. One more thing that happens is, I was talking about wasting tone going off and things going haywire. If in the heart, when the sinoatrial node stops, the atrioventricular node takes over after, but at a different pace. The inner ear, both sides at 40 spikes per second, every axon keeps firing. If there is a deafferentation, what happens to the vestibular nucleus? The vestibular nucleus again should start firing at a particular rate for the recovery to start, static balance to recover. And that can also be enhanced by these kind of drugs, the pacemaker activity, kind of activity that happens. That is how the balance is restored so fast. So in the short term and also in the long term. So in conclusion, and when it comes to future directions, let us not have a dogmatic approach towards drugs. Oh, drugs are good, drugs are bad. No. When there is a streptococcus infection, there is an anti-streptococcal antibiotic that has to be given. For us, doctors, surgery, medicines, exercise, all of them are our tools. Let us not shun one tool as bad, one tool as good, whatever it is. Let us have open-minded, choose the correct tool, not be apologetic about using that particular tool. If it works for something, let us work it, use it. Okay. When drugs work, let us explore why they work and how they work. That will remain, and when it doesn't work in some areas, it will also pave way for exploration of newer drugs. Okay. So with that in mind, I conclude my talks on the histaminergic, central histaminergic system and its modulation, its role in learning, these things. Okay. What was the action of beta-histine, the success of beta-histine treating some of these diseases prompted me to go deep and find this.